Hello, lovely people. Happy Friday. Welcome to yet another version of RLR. There's only one R for now. Hopefully there'll be two. Um, we're very, very excited today to have really somebody who's been part of VMR for a long, long time, who you will immediately be very excited about when you hear that she's presenting a case because um, uh, the last one especially was quite the memory. Shane and I will remember it for a lifetime. I know that. But first order of business is to thank and shout out to people who are making it happen. With Anmol sitting in the lukewarm scribing seat. So Anmol, I hand the mic to you. Um, and please update us on how you've been since you were since it was Anmol week a couple of weeks ago on VMR.
Hello, everyone. My name is Anmolpreet, and I'll be doing scribing today. I'm from India. I'm sitting right now in Punjab, and I loved the discussion we had. And I'm looking forward to the next discussions. And the VMR hours every day, they make my day, and they reduce my stress in the residency match season.
Oh, that's
So
awesome. I'm so glad to hear that. A big shout out to all of you who are applying right now, and that's a very, very stressful time. There's nothing that um, that soothes my soul more than nerding out with you all too. So I'm thrilled to hear that. I see based on the chat that I think Julia might be doing. Is that right, Julia? Are you doing teaching points for now, or am I? You can just say hi anyway, even if you aren't. But I
Yeah,
have
that's
them.
right. I think Mukund is coming soon, but until
Oh,
he's
okay, okay, sounds
trying
good.
to step on his feet. Um,
Yeah,
yes.
you should still say hi. Tell us a little bit about what's going on in your life, and then we'll try to get Mukund to do the same when he hops on.
Yeah, great. My name is Julia. I graduated from med school in Germany this year, and I'm working on a lot of flow cytometry data at the moment. So I'm very excited to do some clinical case discussions every day. It's a nice change.
Y'all, we have to shout out the return of a VMR legend who I just learned. Hi, Maria. I didn't see you here. Hello. You got to tell people what's new, including not telling me that you're coming to the VA.
I'm at the VA now. Hi, I'm Maria. I'm from Guatemala, and now that I say it, I always say that I trained there as well. Very proud of it. But now I'm at UCSF doing my neuro residency, and I'm at the VA, and I just ran into Robbie once in like 5 days. So, looking forward to keep running into him.
Oh, I will definitely try to bump into you more often. As these guys know, I was not at the VA for most of your days there, but I'm back today. I'm very excited for it. Um, well, last but not least, let's say hello to our case presenter, Nicole. Let me hand the mic to you. Maybe reintroduce yourself to the crowd and tell us what you've been up to.
All right. Hi, everyone. I'm Nicole. I am a fourth-year resident at the University of Manitoba in Canada. I'm doing my general internal medicine fellowship right now. I have been very lucky to be a part of VMR for a little bit of time. Got to present a case that was pretty fun for me last time. I'm very excited to share this one because this one, going through with my now junior residents, gave us a lot to talk about, a lot to learn from. So I am super stoked to be presenting today.
Oh my gosh, you sound even more excited than the last time. We've had both excited and very nervous. And yes, Jas is excited that a fellow Canadian is here. I see Prof. Rez has hopped on. Prof. Rez, hello.
Good morning, good morning, good morning.
Is that it, Prof. Rez?
I'm
We're moving on. Okay, all right.
saving my emotional bandwidth and intellectual bandwidth for the case.
I'll translate that. He says, Robbie, stop talking. Let's get to the case. I love the medicine. So, Nicole, without further ado, let's just jump in. I'm probably should hear your voice on Alpha 1, okay?
Sounds good. So we'll start with the first aliquot here. So in terms of the entrance complaint, you guys are going to be seeing a 28-year-old female who is presenting to now the ER with fevers and pancytopenia. That's sort of the one-liner. In terms of a bit of history of her presenting illness, so she was at a hospital outside of the city where she presented with 2 to 3 days of lethargy, tachypnea, and fever. This was in the context of a week prior to this presentation. She had a sore throat. She went to the hospital and got 3 days of ceftriaxone for what was thought to be a tonsillitis or strep throat, but didn't follow up after those 3 days of antibiotics. Given that she had pretty decreased LOC, she was transferred to the tertiary care hospital here overnight. When you're assessing her, she had a lot of neck pain and like throat pain, difficulty swallowing because of that, a fair amount of dyspnea as well, some nausea with non-bloody emesis over the past day. She denied any sort of chills, night sweats, or weight loss, but did have fever, which was mentioned when she came in. Her presentation was quite acute. She felt well for the week prior to coming in. It was just the past few days she's been noticing these symptoms. She didn't have any headache, any vision changes, no chest pain, no palpitations, no cough. She didn't have any abdominal pain, diarrhea, or any bloody stools or urinary symptoms. She didn't have any wounds or sores over her skin, and didn't have any like hair loss, oral sores, or any joint pains or inflammation. So we'll start with that.
Are we ending with that too, Nicole? Or
Sorry.
just starting with it? Thank you so much for all that information. I think there is so much to tackle here. And so I'm going to definitely need the mathematicians' help as always. And I'll just start the conversation, but we might go back and forth, Robbie. And my focus is going to be the fever and the pancytopenia. Maybe I can leave the other elements of the difficulty swallowing and other symptoms to you to incorporate into that initial foundation, initial framework. I think fever is something that we've all have a great approach to on CP Solvers. Like if you've been coming to CP Solvers, it's probably your favorite chief concern to get. And you automatically are converting fever to inflammation, though you know there are non-inflammatory causes of a rise in temperature. Like if someone is under 1,000 blankets in a desert, they're going to have a high temperature and it's going to be hyperthermia, but not fever. In this case, you can rest assured that this is likely inflammation. And whenever you have inflammation, your first start is to make sure it's not something infectious. Though you know in the back of your mind, inflammation can be from cancer, it can be from autoimmune processes, drugs, DVT. So what about the pancytopenia? When you're dealing with cytopenias, the number of cells that are down will influence whether you're primarily in the peripheral destruction, sequestration process, or whether you're at the marrow. The more cells that are down, the more likely you're dealing with a marrow process. Now, there are instances, rarely, where you can have peripheral destruction of all 3 cell lines. And those include stuff like lupus, tick-borne disease, or hematologic malignancies like CLL, where you get immune-mediated destruction of the white cells, the red cells, and the platelets. Whenever you have pancytopenia, you really want to make sure that what is the size of the spleen? And here's where you have to be cautious. Even if the spleen is big, you can't stop there and say, oh, this is just splenic sequestration leading to pancytopenia. And I have to mention, it really helps to know the severity of the pancytopenia. Like it was kind of Nicole to tell us that this patient had pancytopenia, but if the white count is 3 is much different than if the white count is 1. The hemoglobin of 10 is much different than a hemoglobin of 6. But I think if you're doing probability-based reasoning, when you hear pancytopenia, you're like, okay, I'm going to look at that spleen, but probably there's something happening at the level of the bone marrow. Now, at the level of the bone marrow, there's a couple of things that can happen. Either something is suppressing the marrow from doing its job. What can that be? Well, that can be a toxin like alcohol. But alcohol wouldn't cause fever. So you can already start narrowing even amongst your broad schema just with the inflammation. So inflammation and pancytopenia. You can easily imagine someone has a viral syndrome, has cytokine release, and these cytokines suppress the bone marrow. So that's why in anyone with pancytopenia, we're checking HIV, we're checking hepatitis C, and we are wondering, do they have an acute viral syndrome that's leading to the pancytopenia? You can have stuff that infiltrates the marrow, and that usually is in the form of granulomatous diseases. These worldwide, many of us on CP Solvers are practicing outside of the US, and we're seeing tuberculosis or fungal infections in the US, like cocci or histo worldwide. They can certainly invade the marrow. They can present with inflammation, but usually they absolutely can present with inflammation, but usually the tempo, and now you got to use the tempo here, it's not that quick. It's usually not that rapid for an atypical infection. So we talked about something suppressing the marrow, something infiltrating the marrow. People can have nutritional deficiencies. Like the marrow needs its tools to synthesize these cells. And if someone has B12 deficiency, they can have pancytopenia. Folate, copper. So, but those usually don't present with this inflammatory milieu. So I think the inflammatory milieu, based on what we've discussed so far, prioritizes either a viral syndrome and makes an atypical infection less likely just based purely on the tempo. And then there's just one more bucket you have to consider, and that's a primarily stem cell disorder. And unfortunately, in medicine, there's a lot of misnomers, and one of those is aplastic anemia. Because you hear that word aplastic anemia, you're like, oh, it must just be anemia. It's not. It's actually pancytopenia. Like the marrow is not functioning well. In that category is myelodysplastic syndrome, but not at this age range. The one that you really have to worry about in someone at this age range with pancytopenia is leukemia, and specifically acute promyelocytic leukemia, because a lot of times we think of leukemia and we're like, wow, the cells have to be high, right? It's leukemia. It's a stem cell disorder, a mutation, propagation of a bunch of cells. So the white count's going to be 100,000. No, that's a mistake. What ends up happening is that genetic mutation leads to propagation and crowding out of the marrow, but those cells are not healthy cells. They undergo apoptosis. They stay tethered to the marrow. They don't get released out. So a good percentage, maybe 20%, people with leukemia, they actually present with pancytopenia, specifically the acute leukemias and specifically acute promyelocytic leukemia. So now that Rabih's yawning, I'm going to end there and pass the mic to him to then incorporate this other, because Rabih, what we're doing is we're building here. We went from fever equals inflammation. Inflammation is probably infection, but now we brought the pancytopenia and we're trying to say, okay, what overlaps between inflammation and pancytopenia? And we're left at like viral syndrome, leukemia, or some kind of splenic sequestration, though we wouldn't end with that. Mike, to you, my friend.
Prof. Rez, that was absolutely superb, but you made one mistake, unfortunately. That mistake was to misidentify a mucopurulent cough as a yawn.
Dude, I thought this patient had a muco. I was like, oh my gosh, I did it again. I missed one of the main concerns.
Yeah, I think that's the framework we're going to use, and we're going to find an answer on that framework. And I think the question about the sore throat should remain a question, because whenever you have two systemic features like fever and like pancytopenia, if you have a localizing sign like pharyngitis, you want to make sure that you're not being distracted by it, because it's very conceivable that the pharyngitis is actually a consequence of the fact that this patient has no white cells. And so this patient has a separate process causing pancytopenia and easily has a little bit of a pharyngitis that's not the center of gravity. And it's no different than when somebody has some AKI in the context of systemic syndrome. You don't want to pay attention to the kidneys because its odds are it's a pre-renal or ATM. But I think you have to be careful, and you have to not do what I just did. I took sore throat and I turned it into pharyngitis, but we don't know that yet. And I think the most important question in my mind is this sore throat actually a diffuse pharyngeal process, or is it a structural issue? Is there a focal abscess somewhere? Is there diffuse lymphadenopathy in the neck? What is actually hurting this patient? So I think there are three things that I would keep in my back pocket to deploy as rapid interventions for this patient. The first is I want to understand exactly what her upper airway discomfort is from. and very open to a myriad of things. You want to see the smear right away and know what's going on the smear. And then you want to keep your 2 empiric treatments very close to your chest. In a patient who has fever and pancytopenia, your empiric treatment is gonna be tempting to give vancomycin and gram-negative coverage, but the real antibiotic that you need to keep closer to you here is doxycycline, and we can talk about that later. And as Prof. Rez, the other important empiric treatment is ATRA, all-trans retinoic acid for APML. So I think we need to understand the pancytopenia better. We need to understand the sore throat better and not call it pharyngitis. And then what we're going to keep close to our chest is doxy and ATRA. And we might mix them in together and inject them if we need to, because this patient's too sick for us to take too much time on this. All right, I'll hand the mic back to you.
All right, I am loving this. I'm learning lots, even like months after I've seen this case. So we'll start with aliquot 2. Sorry, I'm just sending that to Anmol as well. So in terms of past medical history for the patient, she's got a history of type 2 diabetes. She does have hyperthyroidism, and she has sort of on and off been taking her methimazole. Last time she took it was 2 weeks before this presentation, took it for a week and then stopped. And then she had H. pylori, which was confirmed on a biopsy from an upper scope, but wasn't yet treated. In terms of her medications, so she's taking insulin, both Lispro and Glargine. She's on rabeprazole, the methimazole like we talked about, kind of on and off, and then some atenolol for her hyperthyroid symptoms. Her only allergy is penicillin. We're not really sure what reaction she has to it, more of a childhood allergy. And then in terms of her social history, she is living in a remote community in Manitoba, outside the city. Doesn't have any alcohol use or any injection drug use, but does use cocaine, used a few days prior before she came to hospital. No other cigarette smoking. And that is aliquot 2.
Super, super interesting. And, you know, whenever somebody has such a horrible, hectic disease process, most people have a specific reason why. And if you study their underlying vulnerabilities in most people, you find a reason why they get so sick so quickly. It's very, very unusual for somebody to go from perfectly healthy to being very, very sick without accumulating chronic medical conditions in the interim that fill the void from 0 to 100. And so most people don't go from 0 to 100. They go from 50 to 100, and the 50 is chronic medical conditions. And I think knowing that this patient has diabetes, knowing that this patient has other things going on here, really, I think, fills the void. There are, of course, conditions where people can go from 0 to 100, like tick-borne diseases and acute leukemias. But I think here we cannot ignore the context. And I think the context is very, very powerful. I'll just reflect on the medical history and then pass the mic to Prof. Rez to reflect on the medications. But I'd say here the type 2 diabetes, anytime somebody has a fever, pharyngitis, and type 2 diabetes, you have to render them as immunocompromised. And I think the kind of immunocompromise that we think with diabetes is very, very interesting because it actually extends the whole spectrum of neutrophil deficiencies and intracellular deficiencies as well. So we think of type 2 diabetes causing patients to have all sorts of interesting intracellular infections like disseminated TB and disseminated crypto, which are usually more subacute. But let's not forget that acute neutrophil dysfunction is also very well described. So patients get really bad gram-positive, gram-negative infections, and even fungal infections like Newport. And so I think the fact that she has that is very, very important. There are a lot of ways to connect hyperthyroidism with pancytopenia. It's actually very interesting to reflect on some of them. The most well described is in Graves' disease, where in some small number of patients, the trophic effect of the TSH receptor makes their eyes swell up, causing Graves' ophthalmoplegia, makes their pretibial space swell up, makes their bones and their joints swell up, causing hypertrophic osteoarthropathy and Graves' related clubbing. But also, some patients get splenomegaly from their Graves' disease, felt to be from the same mechanism. So I think the fact that she has hyperthyroidism here is interesting because we don't know the time course of this disease, and it would be interesting to see if she was pancytopenic before. But the medical history is the less juicy part of this aliquot. I'll pass the mic to Prof. Rez to reflect on the meds and other things that take that part.
You know, Robbie, you mentioned something as I'm like Googling that I think is so important. And I will take away the next time like this, an aliquot like this presents itself. You said that, how do we know that the throat discomfort, if it were pharyngitis, is caused by the same process that's driving the pancytopenia and the throat discomfort versus the pancytopenia rendering the patient vulnerable to infection and then picking up an additional diagnosis. So rather than A causing B and C, A causing B and then B causing C. That's clear, right? And I love that point so much because this is what methimazole made me think of. We know it can rarely cause pancytopenia, but rather than trying to solve inflammatory causes of pancytopenia, you have to be open to the possibility that you're just solving pancytopenia with an inflammatory complication. Yeah?
Spoken like a mathematician now. I hereby betrow you the title.
And honestly, that's all I want to say about the medications. I think that really, like, it's so great. Like, is it just pancytopenia and then infectious complication? Or is it some kind of inflammatory process that's driving, the pancytopenia and the throat symptoms? And you have to be open to both. Did you have any other comments you wanted to make? PPIs can cause all sorts of complications, side effects and stuff, but those are always a diagnosis of exclusion. You wouldn't just stop and say this is methimazole until proven otherwise. Absolutely not.
I just want to correct something I said earlier, which is to say that the VANC and the gram negatives are less important in this case, and the doxy is more important. When you have the possibility of methimazole-induced agranulocytosis, which is what Prof. Rez is invoking, a very, very high rate of super infection, as Prof. Rez is alluding, by pyogenic flora. So the doxies become less important now than the gram-positive or gram-negative. No. All right, Nicole, back to you, please.
Sounds good. We'll go on to number 3. So for the exam, in terms of vitals, her heart rate was 132. She was in sinus rhythm. Her rest rate was 32. Blood pressure was about 160s to 170s systolic over about 70s for the diastolic. Her oxygen was 97 on VMR, and her temp at its max was 39.2 degrees Celsius. Sorry for those who are in the States. In terms of how she looked generally, so she looked very unwell, lethargic. She was able to rouse and answer some questions, but definitely falls asleep like right away. She was diaphoretic and had a very hoarse voice while she was speaking. In terms of her head and neck exam, there was no like ocular symptoms or signs like redness or icterus or anything. She didn't have any oral sores or tonsillar exudate, but did have some enlargement of her tonsils that were also erythematous. She did have some mildly enlarged cervical nodes that were moderately tender on palpation. There was no fluctuance or like any abscesses really palpated on neck exam, though. Her neck was supple. She had a negative jolt sign, and she also had no alopecia. In terms of her cardiac exam, it was completely normal, no edema. Her extremities were quite hot to touch was really the only thing. Respiratory wise, she was of course tachypnic with increased work of breathing, but her lungs were clear. Abdominal wise, she was maybe a slightly tender to the epigastrum, but not peritonitic. There wasn't any clinical signs of ascites. And then in terms of skin and joint exam, it was unremarkable. There wasn't any areas of like cellulitis or open wounds. And then in her neurological exam was unremarkable. She had no tremors with regards to her hyperthyroidism.
Beautiful. I'll just reflect on this briefly and then ask Rabih to layer upon that reflection. I think we were all going in this with that this patient's inflamed, like this patient's going to meet SIRS criteria. And in the medication history, the patient's also on atenolol, probably because of their thyrotoxicosis, which we yet to have a specific cause of that. That's not a terminal diagnosis, it's a proximal diagnosis. You just have to keep that in mind. So if this patient's heart rate was like 90, rather than say, oh, this represents Faucher sign and an intracellular organism, no, it just represents beta blocker in someone who's inflamed. But obviously she is tachycardic, as you would expect, and so on with the fever. The tachypnea with clear lungs could either reflect that she has a lactate acidosis and is breathing off the extra acid buildup, or it could be something that just wasn't detected on exam because it's hard. When someone's breathing fast, you might not hear crackles you might not hear that abnormality. Or it could be a vascular process like a PE. I think just like hearing this story, I'm very interested in like a cross-sectional imaging, honestly. Just like, this is really concerning. Like, she's drowsy. So like we've already talked about inflammation. We already talked about bone marrow pathology, but now we're adding an additional symptom that wasn't part of that HPI, which is drowsiness. So is the CNS involved? And the jolt sign, like I actually, I've read like the literature and the sensitivity of like shaking the head and seeing if it worsens. I think it's like, it could be difficult to perform in someone like that's drowsy, but I'm just worried about the central nervous system and whether this process is causing a meningoencephalitis. Like, is this drowsiness encephalitis? Is it inflammation meningitis? And have a very low threshold in someone with such great cognitive reserve, 28 years old. This is not someone with dementia who you could say has a UTI and now is tipped over to confusion. Very low threshold to like perform a lumbar puncture to analyze that cerebral spinal fluid. And it's so easy for me to say discussing this over the mic. And I actually am going to ask Robbie to comment on this as an ED provider who sees this as a front line provider. I just had one last comment I wanted to make before passing it to him to really help us, navigate that space. Is anyone who's young with fever, like sore throat and pancytopenia, you got to think about HIV. And HIV has two cousins, and they're herpes viruses, Epstein-Barr virus and cytomegalovirus. And I remember it as heck, like, what the heck are you doing? So HIV, EBV, CMV, and they can all cause pancytopenia, fever, and a constellation of findings. Robbie, really, I'm curious, as an ED provider, and I know you're not there to see this person, which would influence your decision-making, like how you navigate this.
Well, Prof. Rez, I think when Nicole was presenting, I feel like I can see the person in front of me, honestly. It's such an amazing level of description and clarity on what's going on. And, I'm just going to be like, put myself as the person taking care of this patient, and I would tell myself, slow down, be careful. And let me explain why I would say that to you. Whenever you have a setup for a really rare disease, but a rare but deadly one, things happen in your brain that are beyond your control, especially when you're an enthusiast in diagnosis, because you want to merge everything into that beautiful, like really cool, rare presentation. And let me explain that for those of you who are jumping into this case a little bit earlier, which is this is a setup for methimazole-induced agranulocytosis. So methimazole-induced agranulocytosis is a super rare event. It happens in less than 1% of patients exposed to the drug, but it happens, like in this patient, in the first 3 months. And what happens is the classic description is the patient gets an isolated severe leukopenia with mild anemia and thrombocytopenia, but not a deep pancytopenia, classically. And for some reason, almost all those patients have a pharyngitis. It is not known if that pharyngitis is part of the drug-induced disease or if it is actually an superimposed infection, because most people are also febrile. And so it's hard to separate. So most of these patients get treatment for essentially an infection, and the methimazole is withdrawn. So when you see this case, you're like, how could it not be, if you've heard about it, how could it not be methimazole-induced agranulocytosis? And I think the thing that you have to emphasize is, well, this is not classic. And the reason it's not classic is we don't know the exact numbers yet, but the patient does have a pancytopenia, not drug-induced agranulocytosis. And so I think you then have to say, well, are there other features that are present that are unusual too? And when it's a rare disease, I doubt we have the full spectrum of what it presents like. But as Prof. Rez just said, she's got abdominal pain, she's confused. And of course, all these things could be a sequelae of the immunodeficiency and representative of an infection. But I would just say this is not classic enough, and it's morbid enough that I'm definitely calling endocrinology stopping methimazole, treating for presumed methimazole-induced agranulocytosis, but the morbidity of a more widespread infection, not just pharyngitis, and the morbidity of missing the possibility that this is the person who is actually 99% of people who don't get drug-induced agranulocytosis from methimazole, 99%, who happens to have a hectic pancytopenic picture at the same time as she would be set up for drug-induced granulocytosis. That's very important to think about. And the insight into thinking about it is the fact that she's not actually classic. And if you take 99% and multiply it by the probability of an independent pancytopenic hectic syndrome, I bet it would compete with 0.5 or 1% of drug-induced agranulocytosis. So I would be telling myself, you're a nerd, you love rare diagnoses, be very careful. Could she have lupus? For sure. Could she have a tick-borne illness? For sure. Could she have acute leukemia? For sure. And so I think that I would be very, very careful. But practically offer them methimazole, call HEMA, call endocrinology, broad spectrum antibiotics. If there's any hint of tick-borne infections, and I don't know the geography as Nicole illustrated last time when we missed her case of blasto, I would probably give doxycycline if I didn't know more. So that would be my instincts in the ER, apart from, of course, aggressive supportive care. And then the practicalities of, oh, do I need to do an LP? Like all that stuff, that's the details. The clinical reasoning is like, don't fall for the trap here. And I've fallen for it many times before in real life on VMR, alongside Prof. Raz, by myself, in all scenarios. So I'm trying to be very, very careful. All right, Nicole, I know there's a lot of juice left probably. We haven't even gotten the first round of data yet. So I'll hand the mic to you and tell us.
Sounds good. All right, so we'll go through the first set of labs. So initial labs, sorry, lost my page there. There we go. So in terms of electrolytes, sodium was about 150, potassium is normal, chloride was 118, bicarb was 14 with an anion gap of 16. And she did have a mild beta of 3.7. Her urea was about 8.1, with the upper limit being 11. Her creatinine was 57, with the normal range being about 40 to 100. Her albumin was 14, where the normal is 40. She had a lipase that was checked that was 892. Her liver enzymes, bilirubins, and LDH were within normal limits, as well as her CK and Myo were also normal. Her CRP was 224. Her beta HCG was negative. Her thyroid studies, which I think a few people asked for. So TSH was less than 0.015, so less than the lower limit. Her T4 was 29. Her T3 was 4.3. Her ethanol, acetaminophen, and salicylate screens were negative. And then for her CBC, her hemoglobin was 89. And this is from a baseline 3 months before of about 100 to 120, sort of fluctuating between that. Her MCV was 80.1. Her white cell count was 0.5, and 3 months before it was 8. Her ANC was 0.04. And her platelets were 39, previously in the 200s 3 months before. And then her INR was 1. And you do have a blood gas, so her pH was 7.5, her CO2 23, her bicarb was 18, and her lactate was 2.2. We'll leave it there for the first round.
Professor, maybe I can just tackle the CBC and I think as you anticipated, this patient has a deep pancytopenia. And I think the lowest thing we have is that she essentially has agranulocytosis. She almost has no neutrophils. So she is really fitting that bill, excuse me. Apologies for that yawn. I'm not gonna let it go, Prof. Rez. But yeah, she's pancytopenic. And I don't know how many patients with methimazole are pancytopenic. I don't think it's the majority of people. So I think what that cautionary tale stands true. And it could not have, Prof. Rez told us it's very different when your hemoglobin is 8 versus 10. It's very different that your platelets are 149 versus 39. So I think that she really is pancytopenic. And so that caveat, I think, definitely applies now. What else caught your eye, Prof. Evans?
Beyond you, my friend, some of the data. So, dude, what's wild is we're both sick at the same time with the same illness, and we weren't even around each other. So I think one of the cool things about gaining experience through reflection is like learning what matters in terms of diagnosis and is related to the diagnosis, and what is usually just a sequela of the hectic state that the patient is in, and you have to manage. So briefly, when I look at this patient's sodium, I'm like, 150, that makes sense to me. She's drowsy. It just further confirms that she's probably not drinking water. And so this patient absolutely needs some water, but we just can't give water through the IV. It has to be with glucose. But she's probably nutritionally deficient. So I'm giving her IV thiamine and I'm giving her D5 water to bring her sodium down, because her brain is already vulnerable for whatever process. You don't want to add an additional insult from the dehydration that has ensued due to her somnolent state. Then you look at the bicarb and the anion gap. The anion gap, it's the only acid-base disorder you can diagnose off a BMP. Otherwise, you do need a venous blood gas. And I would be shocked if she doesn't have some ketosis. It's going to be important to see if there's ketones in the urine and whether she is developing DKA. Remember, she is on insulin. Look at that, glargine, Lispro. She's probably dependent on that insulin, and you don't want to miss DKA. And if you ask, how do you treat the DKA HHS? More important than the insulin is fluid. So she needs a lot of fluid, and you have to pay really close attention to that potassium before you give insulin. That's the 3 pillars, my folks: fluid, potassium, insulin. And then you can look at some other electrolytes. The BUN of 8.1, I think, might also reflect some of her nutritional status. As you can see, the albumin is a little bit low. Here, the lipase being elevated, like, could this all be pancreatitis? No. Could whatever process is driving the inflamed state, the pancytopenia, also render her pancreas vulnerable? Absolutely, it can render it vulnerable. And yeah, pancreatitis ultimately is belly pain. It doesn't have to shoot to the back, but that's the classic presentation. An elevated lipase and imaging that shows an edematous pancreas. And then you have to ask, is it alcohol? Is it stone? Is it triglycerides? Is it calcium? Is it other causes? The T4, T3, TSH, remember, this patient has thyroid toxicosis. We didn't really talk about what's driving it, I don't think, unless I missed that. But the most common causes include Graves'. In Graves', you have diffuse hyperplasia of the thyroid gland. It's very vascular, and you hear a bruit. When you have a goiter, you have an autonomous acting nodule that's releasing a lot of thyroid hormone. So you won't hear the bruit, but you might see increased uptake on a radionuclide scan or on a thyroid ultrasound. When you have Hashimoto's, autoimmune destruction of the thyroid gland, the initial phase is thyroid toxicosis. All of those, you would want to stop the thyroid hormone production, and you would want to stop the sympathetic consequences. And that's why she's on atenolol and methimazole. I think the reason her TSH right now is undetectable is probably because she's not taking the methimazole. Remember, she's somnolent. I think there's going to be important to manage the thyroid toxicosis. The lack of tremor doesn't rule out thyroid toxicosis. Could that throat swelling be a goiter, Rabih? And her presentation is just crazy thyroid toxicosis. You can't stratify thyroid disorder based on thyroid levels. You can't. You actually have to use other calculators, and there's a calculator you can use for thyroid storm. But here, she's thyroid toxic from her underlying thyroid disorder and probably inadequate treatment, in part due to decreased methimazole intake. The pH was 7.5, it seems like, if Is that right, Nicole? That's a bit odd because we already know she has that anion gap acidosis. So the fact that she's alkalemic, whenever you have an anion gap acidosis, you got to calculate the delta delta. We'll make it very simple here. You take 16, you minus what the expected gap is based on the patient's albumin. Let's just say it's 12, but probably a little less than that. And then you add it to the bicarb to see if it corrects. When I do that process, I can tell you she also has a non-gap metabolic acidosis. So what the heck is her pH doing at 7.5? It tells you that there's a respiratory alkalosis. She has a triple acid base disorder, anion gap acidosis, probably due to ketones, non-gap metabolic acidosis, which might be related to something going on at the level of the kidney, and then a respiratory alkalosis from her being tachypnic and over driving and over breathing. What I just did there is I interpreted everything. What does it do in terms of our actual case advancement? I'm not quite sure. I'm going to ask Robbie because Robbie, I'm a little tired of interpreting. Maybe you could just summarize and update where we are in the case and what we're looking for next.
I feel you, Prof. Rez. It's been a week, but I think we're both still on the mend. Yeah, I have nothing to add but to share what happened in my mind when we got those thyroid function tests, because I was eagerly awaiting to see, is this a lot of methimazole and a methimazole problem? Or this is insufficient methimazole and a thyroid problem? And I think, gosh, the holes for drug-induced agranulocytosis, I can't even say that right, are now bigger and bigger and bigger because I don't know if she's been taking it. You can't get methimazole-induced agranulocytosis if it's the medication is in the pharmacy, not in your body. And I think that now I'm like, wait, is this thyroid storm? Fever, altered mental status, abdominal pain, and is her neck and her pharyngitis not really pharyngitis, but thyroiditis? Or not thyroiditis, but it's the thyroid's hurting. So I previously said no methimazole, and I am having to retract that too now. It's two retractions, Prof. Rez. And so I would be very worried that she's in thyroid storm. And I think the beta blocker is key. And I don't know how an astute endocrinologist like Dr. Rob Weber would manage this case. Do you give her methimazole, knowing that that's something that at least I think about? Maybe I'm completely off. So, but that's what happened is like now I'm entertaining the exact opposite theory of what I was initially worried about. And I would lean on a lot of help to figure that out. What would happen in real life pearls for you all? Smear is really key. You can't sit on leukemia. You're going to be tempted to do a CT abdomen pelvis with contrast because her belly hurts. You're going to be tempted to get maybe a CTA for a code stroke because she's not waking up. But you have to at least go into that scan knowing that if you give her contrast, you are giving her free iodine. And that may make things a little worse right now. So I don't care about contrast-induced nephropathy. I don't care about allergies that we can control. I think the one real fear of CT scans is the iodine load in thyrotoxic patients. You have to worry about that a lot here. Unbelievably complex case. I would need a lot of help in real life to manage it. Anything else you wanted to sprinkle in there, Prof. Rez, before we hear from Nicole?
Man, I love your point about iodinated contrast. That's really good. I'm really curious to see. And I think the point you're trying to make here, or we're trying to make, is a lot of these are diagnoses of exclusion, especially in someone who's so hectic. The DDX has to be kept broad. And yeah, you can calculate all this stuff, but very curious to see how this unfolds.
All right. I am loving this because my brain was also kind of all like, not that yours is, but mine was all over the place at this case for the last like 2 weeks that I was taking care of this patient. So like the differential was certainly broad until we got some more tests. So I have this aliquot that gives more information. And then the last one will kind of talk about what happened and like who else was involved during her admission as well. The next set of tests she got, so she got a urinalysis that really just showed some hyaline casts, but was otherwise bland. Her urine culture was negative. Her quad swab for a viral swab was negative. She had blood cultures a few times during her admission, a total of 5 sets of cultures, and only 1 bottle of those 5 grew staph epi. She had retics that were 18, with the lower limit of normal being 20. Her blood smear that you get shows no schistocytes, did show some increased echinocytes and acanthocytes. She did get an STBBI panel, so her HIV, Hep B, Hep C, syphilis, all negative. She had EBV testing, so IgG was positive, IgM was negative. For CMV, her IgG and her IgM were both positive. Her parvovirus B19, she had IgG positive, IgM negative. Her immunoglobulins were normal. And then she did get pan-CT'd with contrast in the ER. So she had a CT neck that showed bilateral cervical chain and supraclavicular lymphadenopathy with some fat stranding surrounding the area. There was some prominence of the tonsillar tissue bilaterally, no abscesses, no evidence of epiglottitis, and her airway was otherwise patent on the scan. Her CT abdomen pelvis was unremarkable. And then she had a CT-PE study. There was no PE. Maybe some consolidation in the bases, a bit more on the left than the right, with possible pneumonia, they called it. And then maybe some reactive lymph nodes in the chest. She also did end up getting a bone marrow aspirate with biopsy. She didn't have any evidence of a B-cell lymphoproliferative disorder or plasma cell neoplasm. There was a decrease in all 3 of her cell lines. However, it wasn't like an empty marrow that would be consistent with aplastic anemia. We'll leave it at that.
Wow. Yeah, I'll again just share my thoughts and then ask Rabih to layer upon those thoughts. I think this is exactly what you want to do. And sometimes like having less knowledge is better, because like when you have a lot of knowledge and you might like it's so helpful to have this CAT scan, to be honest, with contrast. It's so helpful. But haven't you ever been in that place, Rabih, where it's like, man, why do I think so much? And in any case, we'll see that the HIV being negative is really helpful. The infectious mononucleosis hypothesis, it just seems a bit off for that illness script. And even though her CMV IgM is positive, it is not diagnosis of CMV infectious mononucleosis in an immunocompetent patient. It just doesn't present this hectic. And to make that diagnosis, you actually have to show histopathology of CMV. And we don't have that here. So I'm not going to dismiss this and be like, oh, this is all CMV. The blood smear is really important. And like really the 2 things we were looking for on those blood smears, you could get a thick and thin based on where you are. We were looking for ticks, so to see if you see any parasites. We were looking for schistocytes, which none were present. And the other thing we were looking for was blast cells and rods, and those weren't present either. And the marrow is so helpful because that further confirms that we aren't dealing with a leukemia and we're not dealing with a microangiopathic hemolytic process. Now, I think where we are in this case is this thyrotoxicosis? Is this methimazole-induced pancytopenia? Or I guess more specifically, agranulocytosis with other cell lines being down. Personally, and we haven't commented on the CT scan yet with the lymphadenopathy with fat surrounding. Not sure what to make of that. I don't know if they're trying to say that there's like infection there or it's just some lymphadenopathy NOS. I think that thyrotoxicosis climbs higher for me, Rabih, just based on what you said, which is like if she overdid the methimazole, or not even overdid it, just had that rare reaction to it, I think I would expect better thyroid function tests. And I'm sure there's something on the marrow that would be more consistent with that, but I'm not familiar with that. So what I would do is I would actually treat her for thyroid storm. And the way I would treat her for thyroid storm is I would give methylprednisolone or IV steroids to block the conversion of T4 to the active T3. I would give her Lugol solution, which is an iodine solution that's PO and should oversaturate this thyroid hormone producing part of whatever her thyroid pathology is. And then thinking of methimazole or propylthiouracil, and some can even use lithium to bind up and prevent the thyroid hormone. But of course, I would have endocrinology on board. I have Robbie on board. The altered mental status can, the somnolence is more reminiscent of mixed edema coma. So we don't have a CSF yet, and she is pancytopenic. So I would involve endocrinology. And in my experience, when it is severe thyroid storm, they respond ASAP, meaning within, I don't know, 12 hours of initiating treatment, you'll see a response if it is thyroid storm. I'm thinking of that patient I took care of in Saipan who had Graves' disease, and literally within an hour of giving her Lugols and steroids and methimazole, like she was just so much better. But Robbie, what am I missing here? Like, where are you, my friend?
Absolutely nothing, Prof. Rez. I don't think you're, I don't think you're missing anything at all. I'm trying to, I was just, the only thing that I was wondering was, sure, TSH is super suppressed. I've never seen thyroid storm with normal. I was just going to ask Nicole, are her T3 and T4 normal, or are they elevated, Nicole? I missed that.
Sorry, I should have clarified. So the T3, the normal range in our lab is 3.7 to 6.9, and then the normal T4 is 9.7 to 25.7.
Gotcha. So her basically interpret that her T4 is slightly elevated.
Yeah, and T3 is normal.
So that's the only pause that I have, Prof. Rez, honestly, is like, we as you said, you cannot use her levels to interpret thyrotoxicosis, but the possibility of thyroid storm, and her TSH is completely suppressed. But that's the only pause I have. I just think, like you said, when you have a bone marrow that's negative, of course it can be falsely negative, but if it's truly negative, I think there's only really three possibilities in general. Is the patient has a systemic infection like a tick-borne disease. Patient has lupus, which the lack of proteinuria here is a clue that it might not be lupus, though NA would be best test. And then finally, the effects of a substance. So if this patient had, you mentioned alcohol, but it wouldn't cause the fever. The fever may be fever may not be the underlying issue, maybe a complication. Chemotherapy, and the last substance is thyroid hormone. So I agree with you. I think the questions I would be grappling with my mind would be, while we aggressively empirically treat the thyroid, would I give her doxy? I don't know, but I would probably get an NA. I can't think of anything else. I'm really, really excited to learn, Nicole. No matter what the answer is, the management of this case and threading the needle is got to be so diaphoresis inducing that I feel like my TSH would become suppressed. So take it away.
All right, so what happened to her in hospital? So actually ICU had ended up seeing her first, and the one thing I didn't mention, so it wouldn't cause people to go down rabbit holes, is she did come in DKA, so she was getting resuscitated from that perspective when she first came in, and it resolved within hours of her showing up to the tertiary care site.
We got one diagnosis right so far, for the record.
So she got admitted to internal medicine. We put her on, while we were waiting for cultures, meropenem vancomycin, which she got a total of 7 days of just empirically. She also got 3 days of azithromycin when we saw the pneumonia on her CT chest, and she was having a little bit of a cough. We did get hematology and endocrine involved on the first day that she was in. So hematology did the bone marrow, and they suggested doing GCSF for her, given her neutrophil count and the fact that, we weren't sure she had what her underlying infection was that was driving such an inflammatory response. So she ended up only needing 3 or 4 days of the GCSF with an improvement in her white cells, after which we stopped the GCSF. With that, her other cell counts also improved, even just with time really was the biggest thing. Endocrine did recommend stopping the methimazole. They weren't totally convinced. She was in a thyroid storm at that point. I guess just some of the things like the T3 being normal, the decreased LOC, you mentioned the lack of tremor isn't diagnostic for, or the tremor being present isn't diagnostic for thyroid storm, but they didn't have a huge push to push for treatment of thyroid storm. Also, her thyroid studies were similar to, I didn't tell you guys this, but it was similar to a few months before as well. They hadn't changed very much. So they wanted to watch and just see how she did with the treatment with antibiotics and GCSF. Before she was discharged, she actually got a TRAB, like the thyroid receptor antibody, that was slightly elevated. So the plan was for outpatient ENT follow-up for what was thought to be a diagnosis of Graves' disease. And in retrospect, just talking with my staff about like what this could have been, I was wondering, like, could it be methimazole-induced agranulocytosis then predisposing to an infection? My staff kind of seemed to think this was more in keeping with a CMV mononucleosis that could have caused like the high fevers, the lymphadenopathy in the neck, the sore throat, the thrombocytopenia, which I had to look this up afterwards. Like apparently the severe thrombocytopenia and neutropenia can be associated. So this was sort of, I think the more leading was a CMV mononucleosis, but a background thought being, is it the methimazole? But could never really confirm. I think the one thing I regret we didn't get was a CMV PCR. I think that would have been quite helpful to say one way or another.
Nicole, that's incredible. And I'm smiling because I think Rob and I are now 1 for 3 on CMV, infectious mononucleosis. And what I'm smiling about is I probably spent like 15 hours studying CMV, and despite doing all that in the moment, but in retrospect, I think it makes it's a great way to explain everything. And for these patients who are immune competent, you don't really need to treat, right? You just you guys didn't do any kind of antiviral therapy, like ganciclovir or anything. Yeah, that's what I thought.
No, she just got
So my
better
15
like over
hours
time.
of investment wasn't completely wasted. Anyways, I just wanted to thank you so much. That was like incredible, and it makes a lot of sense. And yeah, Ravi, we're 1 for 2 on this one today.
Good thing good thing that there are wonderful people taking care of the patient and we get to learn. Yeah, Nicole, I have nothing to add in terms of a reflection. I think this is a case where you really, really have to be very broad in your workup and very cautious. The patient does not have, and if I were to query all my illness scripts, the patient does not have perfect alignment with any single one of them. But I think what matters the most is like what happened over time. And I think what you used as treatment doesn't really fully explain why the patient got so much better. So I think the most intriguing hypothesis is that of a spontaneously improving process. And with a positive CMV IgM, pretty good. And when you go back to like high fever, cervical lymphadenopathy, I think it's a really, really good diagnosis and one that explains a lot of things. I'm curious, how was it like for you to like navigate this in real life, and what teaching can you impart from that?
And it was one of those cases where like my mind was just buzzing as soon as I saw her. Like first, obviously, she looked real unwell, and ICU already said they like didn't need to do anything specifically for her, which was totally true. But I think it was just trying to break down the pieces, like you guys mentioned, like the sore throat, the fever, the belly pain, which I think there was a lot of red herrings in this case, like the belly pain and the lipase and stuff. Like her lipase improved almost immediately, like the next day. So I think there's a lot of things that I think I was tempted to run in different directions with. But I think just asking consultants was the biggest thing, like getting them involved right away, seeing how she did with even just time. Like I think one of the biggest things I've learned in residency is sometimes just watching a patient, like taking things slow, actually you do see improvement pretty quick rather than, for example, heart failure, like diuresing them to the max, you dry them out, you give them fluids, they end up back in heart failure. So I think that was one of the biggest lessons I have taken from residency and also from this case is like sometimes watching works. And it did for her. She got so much better in the 2 weeks she was with us and she got discharged. So yeah, it was definitely a good one to work through. Very humbling case for me.
Couldn't be more grateful for you guys sharing, for you and your staff sharing it with us. Is like the lessons will bleed over well into the weekend for me. I'll be thinking about this a lot, and we'll be like, what the heck, Ravi? Why don't you think of CMV earlier? And then Prof. Rez is mnemonic, HIV, EBV, CMV will come to haunt me over and over again. But I really, really appreciate you, Nicole.
I was gonna say thank you so much for letting me present, and it was so amazing hearing you guys work through the case. Like I learned a lot from listening to people with more experience, like how they think and how they work these things up. So thank you guys so much.
Always a pleasure. We hope you're here every day. But we'll take it whenever you're able to make it in your very busy schedule.
Thanks.
All right, Mukund, the mic is yours, my friend. Mukund, I see that you're unmuted, but I don't hear you. Is that a guy? Oh, there you
Better?
go. I hear
Okay.
you. Yeah.
Okay, great. Sorry for the background noise. I will be brief, just highlight some of the things I thought were particularly interesting about teaching points from today. We started off with a classic discussion of hyperthermia versus fever as a cause of elevated temperature, with fever being correlated with inflammation. We went through a schema for pancytopenia. We talked about what a sore throat actually is, a very philosophical question. A couple of the really interesting teaching points I learned from today were that up to 10% of cases of Graves' disease may present with hypersplenism, or splenomegaly, I should say. I learned about the jolt sign, which is new for me as a test for meningeal irritation. We learned about this really interesting phenomenon in which methimazole-induced agranulocytosis very commonly presents with fever and sore throat, with up to 80% of cases of this rare phenomenon presenting with sore throat, for which patients are actually counseled to stop taking the medicine. The other couple of teaching points I wanted to focus on were this concept of a delta-delta ratio, which I've heard Prof. Rez talk about a few times on VMR now, but for those who have this as a new concept or for whom it doesn't make total sense, myself included, the way this works essentially is to take the delta of your anion gap, divide it by the delta of your expected bicarb minus your true bicarb. And if that ratio is less than 1, it signals that there may be a non-gap metabolic acidosis co-occurring with a gap metabolic acidosis. In this case, the albumin was low, so the expected anion gap is calculated by 2.5 times albumin, with a normal albumin of 4 to 5, giving you an expected anion gap, which we all know of as 12. In this case, the expected anion gap might be lower than 12. The last couple of things worth considering: iodinated contrast as a predisposer or worsener of thyroid storm, and learned about this use of cholestyramine or cholesterol, which are bile acid resins, as a kind of last line treatment for thyroid toxicosis. It turns out they apparently enhance enterohepatic excretion of thyroxine or T4, which can help control hyperthyroid symptoms. That's really it for me.
Oh my gosh, so crisp and so to the point and so accurate. I really, really appreciate it. Sorry, I lost my screen there. Really, really appreciate you, Nicole. That was a real treat. Unmol, I don't know how you kept up with the scribing of such a complicated, fast-paced case, but you did it. And Mukund, it's not easy to take a really, really complicated case and pick like a small number of teaching points that stood out to you. So I really appreciate you're doing that, and the ability to do that is one that requires a lot of effort and experience. So thank you so much. All right, y'all have a great rest of your Friday, and hope to see you guys around. Bye.